correctly identifying the source of lower back pain or lumbar spine pain can be incredibly difficult. As a clinician, we try to do our best to determine what structure is causing the patient's lower back pain. Now that seems simple enough, but a lot of times it's incredibly difficult due to the overlapping pain referral patterns from different structures in the lumbar spine. The structures in the lumbar spine that we feel confident are potential pain producing are as follows. We have the disc. We know the disc can be painful. We have the facet joints. We have the sacroiliac joints. We use this thinking in the office and in the research to try to classify lumbar spine pain to kind of determine the primary pain generator. In the study that we're going to look at in this video, it breaks it down into disc, facet, SI joint, and other. As you can see, the percentages over here are the frequency that chronic low back pain patients present. This is the primary structure. So with the disc, it's 42% of the time. The facet, it's 31. The SI joint, it's 18. And then the other is 9. We're going to dive in an attempt to identify the primary structures causing lower back pain. We have 3 procedures, and those 3 procedures are targeted at the 3 categories of lower back pain we discussed previously: disc, facet, SI joint. To understand if it's the disc causing the pain, we have a procedure called lumbar discography, which basically attempts to make that patient's pain worse through targeted stimulation of that disc. Very uncomfortable. It's a research-based study. We're trying to determine what structure, what specific disc is causing that. For the facet joint, we have what are called medial branch blocks. We actually block the nerve that is the sensory nerve of the facet joint, and if the patient's pain gets better, then we can be sure or confident that that structure is causing the pain. And then for the SI joint, we have what are called intra-articular SI joint injections, meaning we actually inject medicine, localized anesthetic into that joint, and if the patient's pain gets better, then we can be sure that that is the structure. Those are diagnostic procedures attempting to diagnose or find the specific structure causing the lower back pain. From a conservative management standpoint, those are not available to us. We have to use our medical colleagues to do those studies, but what we want to be able to do is, from a physical exam and a history, can we understanding different physical exam and history-based questions allows a conservative care physician such as myself to put a patient with lower back pain into those different categories without the need for expensive or invasive testing that we reviewed previously: the lumbar discography, the facet joint or the medial branch blocks, as well as the SI joint injections. So if a patient centralizes with a mechanical examination, then we can be very confident that the primary pain producing structure in that patient is the lumbar disc. Now on the flip side is if we have a cluster of sacroiliac joint tests and 3 or more of those are positive, then we're more likely thinking that the SI joint. And then lastly is, where is that pain located? Is the pain in the paravertebral structures? Is it directly midline? Does it go in the hip, into the thigh, down the leg? Being able to correlate the patient's presentation and history with different targeted questions allows us to put that patient as what is the primary source of their lower back pain, without the need for expensive or invasive testing. And what gets me super excited about being able to subclassify lower back pain into the different categories is then we can target with different methods, whether it's dry needling, exercise, manipulation, home exercise, general activity. We're able to give the patient the best targeted treatment that we possibly can. And if we can't necessarily put them into a clean box, then we know that we can talk to the patient about that. We can focus more on a general exercise routine, getting used to different provocative activities. So all in all is that being able to subclassify lower back pain is of the utmost importance, because even if we can't put you into the neat and tidy little category of disc, facet, SI joint, maybe it's a combination of multiple, or maybe you're in that other category, at least we know that now. And that's important to be able to predict outcomes, tell the patient honestly and straightforward, this is what you can expect with treatment, here is the timeline, this is how many visits it's going to take. And that is what we try to do. We try to subclassify the lower back pain, have a plan, lay out a plan, understand what treatments are more likely to benefit the patient, and then the rest is just putting that into action and then tracking the outcome. So if you have any questions, if you have lower back pain that has been frustrating, unresponsive to treatment, I would love to be able to evaluate you, be able to help you out, figure out if we can put you into one of those nice 3 boxes, or maybe you're in the other category, and figure out a plan to get you better and get you doing what you want to do.